afternoon. I'm delighted to talk with you today and to share some of what I've learned over the years in prescribing for older patients, or what I also like to term avoiding polypharmacy. Next slide. Okay. So what I'm hoping to cover is pharmacokinetics and pharmacodynamics. You may have remembered those words from medical school, and I'm going to define them and talk a little bit about them. Adverse drug events and safe prescribing. So what I hope you take away from this is how not to make your patients sicker with medication. Right. Yeah. All right. So as I said before, this is the first time I've added Slido in. So go ahead and answer and tell me what you think older adults, what percentage of prescription drugs do they use, taking into account that they're 12% of our population. Whoop, I don't think it's working because I'm not getting any answers. Ah, there we go. So, all right. So that's actually pretty good. I have some overestimates, and the answer is they use about a third of all prescription drugs. So if you look at this, right now, 12 to 13% of our population is over the age of 65, but they buy a third of all prescription drugs. So if you look at the light green, that's people less than 65, they use more prescription drugs, but it's disproportionate if you look at the comparison between the younger and older groups. What about the average number of prescription and over-the-counter drugs taken by older adults? That's great. So the answer is yes, 6 prescription and 3 over-the-counter medications. So we're going to talk more about over-the-counter medications because those are things they don't tell us about. They don't tell us about the herbals and over-the-counter. More than half of people take at least 5 medications, and up to 20% take 10 prescription medications. In nursing homes, it's even more, especially since they write PRN meds for everything you can think of, from diarrhea to constipation and fever and dyspepsia. So is this a problem? Yeah, it is, because up to 30% of geriatric admissions can be medication related. 2/3 of nursing home patients have adverse drug reactions, and we're going to talk about adverse drug reactions. In this population, they're up to 5 times the risk for adverse drug reaction, and depending on the studies, up to 80% have some degree of non-compliance. If you take more than 7 meds, you have more than an 80% chance of having an adverse drug reaction. So these are pretty impressive numbers. And a third of all our ambulatory patients experience one. So if you think about it and think about your patients, then and look at, are they stopping their medication because of an adverse drug event? You'd be surprised at how many there are. And then there are the inappropriate prescribing, and we're going to talk about the Beers criteria and inappropriate prescribing. So to give you just an example, this is my friend Eddie. So Eddie, unfortunately, is not with us anymore, but Eddie came to me as a patient about 15 years ago. He was a very remarkable man. He was first referred to me because of altered mental status. And he was sent to the emergency room of another institution for altered mental status. And He had the mega workup. He was put on telemetry, had a CAT scan and MRI, had an EEG, had carotid Dopplers. And he was sent to me for a dementia workup. And Eddie came in and I started talking to him. And he was oriented and he didn't appear to really be demented. But when you asked him more questions, he had low health literacy and had a very low educational level. He had been in 7 foster homes. And when I asked him what happened the night before he went to the emergency room, and he said, couldn't sleep. So I took some medicine for sleep. And I started asking Eddie what he took. And he told me, I took Benadryl. How many? And he puts up 2 fingers. And I said, that's all? And then he said, I woke up again and took 2 more. By the end of the night, Eddie had taken 8 tablets of diphenhydramine. And he was lethargic, confused for days. And they just decided he had dementia. So it was more likely he had drug-induced delirium, and he also had all the side effects of the anticholinergic effects of diphenhydramine. And he really didn't have underlying dementia, but he was labeled with that diagnosis because of medication usage. And that picture up there is a self-portrait that Eddie did, and he was a self-taught artist. So there are a lot of challenges ahead in terms of prescribing for this group. And the question is, what are they and are you up for it? So we start out with the older adults have multiple acute and chronic medical conditions, right? 80% of all older adults have at least one chronic medical condition, okay? And 30% have 3 or more. They have multiple prescribers prescribing multiple medications. So many times I have patients come in with the bottle. I will do a drug review. I ask them to bring the bottles, and I will get 2 bottles of the same medication by 2 different prescribers, and they're taking both of them because there was no knowledge that this was the same medication. So health literacy plays into this as well. There's altered pharmacokinetics and pharmacodynamics, and we're going to talk about that. Adverse drug events and interactions. Indications. Do they really need that med, and why are they taking it? The fact that they're taking multiple over-the-counter herbals, nutraceuticals. Compliance, financial constraints. Patients who can't pay for their medications, and we're going to talk about that. More drugs are available every year that we need to be aware of and understand the effects on older adults. Formularies for Medicare Part D and other drug plans change all the time. So a medication that had a lower copay may become a higher tier drug the next year, and then they can no longer afford it. So there are really a lot of challenges. So can we break through this? Do we just have to accept it? No. But why is it so hard to break through? So polypharmacy, they come and there's such a long list of drugs. I don't have time to go through it. The best drug may be more expensive and they can't afford it. The concern of, I don't want to touch that medication, somebody else prescribed it. Somebody else may not be in the picture anymore, or may not be as savvy as you are now about drug interactions, adverse events, and prescribing in older adults. It's hard to communicate with other physicians about prescribing. I saw a patient yesterday with syncope and bradycardia who was on galantamine for his dementia from his neurologist, who, although the patient was bradycardic at the time they were there, didn't stop it. We stopped the galantamine and, had to communicate with the neurologist that we were doing this. It was incumbent upon us when we saw that problem to stop it and not say neurologist prescribed it, neurologist's domain. Patients may be unwilling to change. Now, You know, I've been taking digoxin for 25 years. They told me I needed it for the rest of my life. And again, not wanting to touch a medication that someone else has prescribed. So I said, I'm going to move on and talk a little bit about pharmacokinetics and dynamics. Pharmacokinetics is what the body does to the drug, the absorption, distribution, metabolism, and elimination of the drug. And it all can be altered in older adults. Starting with gastric absorption, okay? So from the time that drug hits someone's mouth, they may have dry mouth, altered salivation, can't swallow it, decreased esophageal motility, more likely to get piloesophagitis, decreased gastric emptying, so the drug may not move through as quickly, decreased intestinal blood flow, decreased absorptive surface, change in gastric pH, and medications that may be prescribed, that may be affecting gastric pH and acidity may affect drug absorption. So definitely, you know, PPIs can affect absorption and H2 blockers of other drugs. And vitamins can affect the absorption of other drugs in the gut. So for example, calcium and levothyroxine can't be taken at the same time or they won't be absorbed. Or two cations like calcium and iron can't be given at the same time because they won't be absorbed in the stomach. And then we can talk about IM and sub-Q absorption. So there's a decreased muscle mass with age, decreased peripheral circulation, skin changes. So you may give an IM drug to somebody who has very little muscle mass, and you're not sure how fast that drug is being absorbed. It's a problem for IM drugs. Skin changes and connective tissue changes will change topical absorption. Actually, that's here. So there will be a decrease in skin hydration and collagen. So they may absorb a topical steroid more than you thought they would. There's also an increase in absorption from things like eye drops. So I've seen bradycardia occurring from Timoptic or Timolol eye drops because of the absorption through the eye. Distribution, body composition changes with age. As I mentioned, decrease in muscle mass, increase in total body fat, and a decrease in total body water. What does that mean for drugs? Well, it means that if a drug is water soluble, it's going to be in a smaller volume of distribution with a greater effect more quickly. So my favorite example of this, or as what one of my colleagues calls, why older adults are cheap drunks. Because alcohol is water soluble, decrease in total body water, alcohol level gets higher much more quickly. A drug that's fat soluble, so increase in total body fat, like diazepam or Valium, is fat soluble. So it hangs out in fat and gets released slowly. So it makes that, it hangs around a very long time. And then there's also decreased cardiac output. So drugs may not be distributed the same way. And there are altered tissue barriers. So for example, there is a decrease in the blood-brain barrier, which is why you might get more cognitive adverse events and side effects from medications in older adults. Liver metabolism is not affected quite as much as some other things, but it's important to know that there can be a decrease in hepatic mass and liver blood flow, which can affect metabolism in the liver. A lot of drugs have cytochrome P450 drug interactions, and there may be decreased enzymatic activity as people get older. As we are prescribing more and more Paxlovid, this becomes really important in looking at those P450 drug interactions. Albumin decreases with age. So a drug that is protein bound, there may be more free drug. Good example of that is dilantin or phenytoin. You may get a level that appears normal and not toxic, but the free drug level is in fact elevated. Elimination. GFR declines with age at 1% per year after the age of 30. Remember, normal creatinine does not equal normal GFR or creatinine clearance. If you have a 90-pound 90-year-old with a creatinine of 1, that's a reduced GFR. So you can look at, the automated labs you get an estimate. Remember, that's just an estimate. It's not taking into account the patient's body weight. So if you really need to know, I encourage you to use one of the formulas that are available to you, like the Cockcroft-Gault formula, to calculate creatinine clearance, because it does include age and weight. And this becomes very important in drug prescribing and drugs that are renally excreted. Pharmacodynamics is what the drug does to the body. So what is the end organ effect? Why are older adults more susceptible to benzodiazepine side effects? So as I mentioned before, decrease in the blood-brain barrier, decreased synaptic activity, and the receptors may be more sensitive. The only ones that are less sensitive are beta blockers, and actually you may need more beta blockers to be blocked. There are also decreased baroreceptors. So what a good example of that is, you have a patient who you give a diuretic to, and they stand up, their blood pressure is lower, they vasodilate, their baroreceptors don't kick in, so they don't vasoconstrict to bring up their blood pressure, and they have a syncopal event. There's less sensitivity to things like hypercapnia. So that patient with CO2 retention may not appear that way, in the same way. There's less of a response. The sedation doesn't allow them to then become tachypnic, the same way you might see it in a younger person. So I mentioned earlier that they're also more susceptible to adverse drug events. And I really love this cartoon. Side effects can include loss of appetite, job, home, family. So everything you can think of can be an adverse drug event. If ranked as a disease, okay, adverse drug event would be the 5th leading cause of death in older adults. That's a pretty impressive statistic. It may be thought to be part of normal aging, what we're seeing. So think about the most common adverse drug events. Confusion, dementia and delirium cause are more common in aging. Ataxia, they have a little gait dysfunction. Incontinence, aren't all older adults incontinent? Dizziness, well, so many of my patients have dizziness. Are these really adverse drug events, or are they part of normal aging? So as I mentioned, study, although it's older, it was pretty impressive that they looked at more than 4,000 admissions to Harvard-based hospitals, and they looked at adverse drug events and preventable adverse drug events. And there were millions spent on adverse drug events. And what was more impressive was how much was spent per year in preventable adverse drug events. So medication errors, people being aware that they might have been sensitive to a drug. So what do you think are the greatest risk factors for adverse drug events? And you can pick as many as you like. So you So it's actually age greater than 85, not age greater than 50. So age greater than 85, low body weight, not high body weight, 6 or more diagnoses, creatinine clearance of less than 15, I think everybody got that, 9 or more medications, 12 or more doses a day, and having a prior adverse event, which I think everybody got as well. So think about these when you're prescribing for older people, those older, frail people with multiple diagnoses and a decreased GFR. Think about every drug you prescribe. Is it indicated? And am I dosing it correctly? What accounts for the most common adverse drug events? Well, you could have guessed this, I'm sure. So cardiovascular drugs, antihypertensive, antiarrhythmics, diuretics, psychotropics, meaning antidepressants, benzodiazepines, antipsychotics, antibiotics, believe it or not, anticoagulants, analgesics, anticonvulsants, and my very favorite, the anticholinergics. Anticholinergic drug side effects can be seen with so many over-the-counter drugs. So all of the drugs that are sleep aids that are over-the-counter, most of the sedating antihistamines, the drugs for motion sickness, drugs that are given for colds and flu, all of them have anticholinergic side effects, which are associated with confusion, urinary retention, constipation, blurry vision, and dry mouth. We also have to worry about drug-drug interactions, drug-nutrient interactions. So I mentioned a good example of a drug and nutrient is calcium and thyroid. And drug disease interactions, and I'll talk a little bit more about them, are things like giving diuretics to people who have incontinence and making their incontinence worse, right? A number of years ago, took care of a patient. It's where I first met Dr. Andrilli working at St. Vincent's Hospital, and I took care of a patient on a geropsych unit. The patient was admitted on a weekend. Her labs were drawn. She was on a diuretic. It was hot. It was August. It was the summer. And she was prescribed an SSRI. They drew her labs and started her SSRI. On Sunday, she had a seizure. Intern went back and saw that her admission sodium that no one had checked was actually 125. The sodium after the seizure was 112. That's why she seized. She was taking a diuretic. It was hot in the summer. She was hydrating with free water. She said, I was told to drink lots and lots of water. And then she probably developed some SIADH from her SSRI. So she had an adverse drug event, drug interaction, drug disease interaction. She had them all. So this is just some examples of things to think about in drug-drug interactions. And I'm sure you're familiar with some of these. You know, ACE inhibitors and diuretics causing hypotension or hyperkalemia when we give drugs like spironolactone with an ACE inhibitor. The benzodiazepines and antidepressants. And I'll show you an example at the end of a case of a patient who came to us with so many of these drug interactions. Drug disease interactions. So what I mentioned, incontinence and giving patient diuretics. Dementia and benzodiazepines are anticholinergics, also causing increased confusion. Constipation and giving patients anticholinergics, tricyclics, calcium channel blockers. Falls and almost any drug that can be psychoactive or alter blood pressure can increase the risk of falls. Adverse drug reaction from patient error is something else to think about. And interestingly, it occurs most commonly in hypoglycemic medications. So taking insulin inappropriately, older adults being unable to read the calibration either on a pen or in a syringe. Okay. One of my favorite stories, and this brings up patient education as well. I was a geriatric fellow and I had a patient whose blood sugar was not controlled and he was on insulin, and we kept increasing his insulin and we kept increasing his insulin and couldn't get his blood sugar to be controlled. So we said, we want to see how you drop your insulin. Maybe there's a problem there. So he comes in and he brings in his insulin bottles and he brings in his syringes. That sort of dates me a little. He didn't have a pen. And he draws up his insulin properly and he does everything correctly. And he takes an orange out of his bag and injects the insulin into the orange and eats it. Because when he was taught to inject insulin, the nurse educator taught him to use an orange to inject the insulin. And that's what stuck with him, that he needed to inject it into the orange and eat it. That's patient error and educational issues. And then I like to talk about the cascade effect. The cascade effect is you take a drug, it causes a problem, it then continues to cause more problems that are being treated with other drugs. One of my colleagues had a patient who had esophageal motility issues and was given Reglan or metoclopramide, right? If you remember, it works on dopamine. Patient developed a tremor. He went to see a neurologist and didn't share with the neurologist what else he was taking. So the neurologist treated him for an essential tremor with propranolol. He then developed depression. And he was put on an antidepressant by his internist. He then saw my friend, the geriatrician, who looked at this cascade of prescribing of the metoclopramide causing the tremor being treated with propranolol, which is a beta blocker that causes depression, and then he was given an antidepressant. So it's truly a cascade effect. Herbals and over-the-counter drugs. About 25% of older adults use herbals. More than half of them don't report it. The ones I want you to always remember are the G+. So ginkgo, garlic, and ginseng. Benign, no problems with these, right? Well, no. They all cause platelet dysfunction. So if someone is pre-op, having surgery, these should be stopped. The ones to add to that are vitamin E and fish oil will increase platelet dysfunction. So patients take analgesics without telling us. We saw a patient in the office yesterday who had a fall, and that was a whole other story why she had the fall. But she came in what looked like worsening heart failure. Her family was giving her a lot of nonsteroidal anti-inflammatories, which it will increase salt and water retention, and she was markedly edematous. They often don't know the active ingredient of what they're taking, and they assume it's harmless, whether it's, the anti-inflammatory over the counter or the sleep aid they take that they're unaware of, that these are antihistamines. Herbals for depression, like St. John's wort, induces P450, okay? And so it has to be treated just like an SSRI as well in terms of tapering it. Ginseng can interact with sulfonylureas, and we could go on and on. So these are not necessarily benign. What's the indication for the drug? Take the yellow pill to feel honky, the green pill to feel honky, and the yellow pill to feel dory. Do people know why they're taking them? Do we even know, right? So this is just a list of the most commonly prescribed drugs. So think about it. I think some of them we're pretty good about looking at, like PPIs, and saying, you know, they were discharged from the hospital on it, they don't need it anymore, let's try to stop it. But people often come with a long list of vitamins and minerals that they don't need to be taking, assuming they're benign, and they don't stop them. And one of my joys is deprescribing, and we'll look a little more closely about how one can deprescribe. But do we also undertreat older adults? Again, this is an older article, but it was really impressive because it looked at people in an assisted living who had certain diagnoses, and were those diagnoses being addressed appropriately? So I think that there, especially with anticoagulation in people on atrial fibrillation is another one, that 85, I'm not going to anticoagulate them. They have to look at the individual risk factors, not necessarily the age. The Beers criteria for potentially inappropriate medications can be a really helpful tool for you. It was originally developed by to look at problems in nursing homes in the 1990s. And it's been updated every couple of years by the American Geriatric Society. It's actually in the process. The last one published is 2019, but there is one coming out. And it has evidence-based recommendations of prescribing. What should be avoided, combinations to be avoided, use with caution because of potential side effects. Sometimes in nursing homes, you'll see that you'll get an alert that says this drug is on the Beers criteria. You might get a letter from a managed care company or that your patient is on a medication in the Beers criteria. So it doesn't mean that you can't prescribe it if they need it. It means think twice, prescribe with caution. There are great resources for you on the American Geriatric Society website. You can download the Beers criteria pocket card free. There's also a free app, and there is educational materials for older adults, like 10 medications you should avoid, and medication diaries. So these can be helpful to you in doing patient education. Medication monitoring for side effects. Ask them, you know, make people aware before you give them that prescription. These are the side effects to prescribe. We've all been prescribing a lot of Paxlovid because of our COVID positive patients. And about 2 days into it, I get a phone call, almost regularly. Ugh, I have a terrible taste in my mouth. I can't take this drug anymore. Now everybody gets told, when we first prescribe it, you will get a metallic taste in your mouth. Do not stop the drug. Use sour lemon candies. So if you're aware of a common side effect, alert them to it before they stop the drug, and don't tell you about it. Be aware of issues with prescribing. So patients can get mixed up if drugs have very similar names. Try to let them know what the brand and the prescription name for the drug is, so they have an awareness. A lot of the pharmacies will put both the names on a bottle, and that can be very helpful. So this is a picture of bottles from different pharmacies. I have to say, Target was bought out by a chain pharmacy and no longer uses this bottle, which I'm very sad about. You give somebody a bottle and look at the writing. If you have some visual impairment, can you even read the top? Not so much. Can you read the next one? Maybe a little bit better. So the one that's the Target pharmacy, this was actually somebody's project. It was a design student And they designed this for a final project for a design class, and it was bought up by Target. So it has the medication on the bottom. It also has a colored ring for each member of the family. So if 3 people in the same family are filling prescriptions at that pharmacy, a different colored ring was put on the bottle so they could differentiate. I had 2 patients who were visually impaired who insisted on pre-pouring their own medication. And it was quite a challenge because I couldn't figure out how they knew which medication was his and which medication was hers. Look at the covers of these bottles. So the top bottle, those are all childproof caps. By law, the pharmacy has to put on a childproof cap unless they get permission not to. But the top bottle has a reversible cap. So if you get that childproof cap off and they want to switch it, they can turn that cap upside down. I've had patients not take their medication because they couldn't get the childproof cap off. And then we come to high cost of medication. So I gave a talk on prescribing to a group of urologists, and I put together this slide, and I was pretty shocked, okay, about the cost of drugs for urinary incontinence. So oxybutynin, the drug with the most side effects, the most anticholinergic side effects, is the cheapest drug. Okay? Troxium, or brand name Sanctura, is the next drug that's in terms of cost, still pretty costly, which is why Medicare Part D will always ask, they can sometimes say, nope, this is a higher tier drug, well, you need prior authorization. Have you tried the less expensive drugs? And they ask you, have you tried oxybutynin? And it's the reason that it's used. What's not on, oh, actually it is, I added Mebegron to this slide, is also pretty expensive. Oxytrol patches, prescription oxytrol patches, or oxybutynin is a patch, is a great option for people because it bypasses the gut, right? And you bypass some of the side effects, not all of them. Interestingly, you can actually buy these over the counter, and they're less expensive than getting them as prescription. Think about non-drug alternatives when you're looking to treat somebody. The fallback should not always be medication. Sleep protocols are really important. Ask the patient about what's their sleep habits, when do they go to sleep, how much caffeine do they drink, when do they stop drinking caffeine, are they getting up because they are short of breath or because they have leg movements like restless leg, or to go to the bathroom. So then we can address some of these things. We can also use bright light therapy for sleep issues, for delirium, for depression, which can be very helpful. Aromatherapy with lavender can actually help for sleep and delirium. You may say, I don't believe in this. This is hocus pocus. But what harm does it have? It's worth trying. You can put some lavender under somebody's pillow, or especially in patients with delirium and dementia, use lavender oil or moisturizers with lavender to have them rubbed into their hands and feet. Always ask about diet. I will have my learners who tell me about the patients with hypertension. And the first thing I said is, they follow a low sodium diet? And they said, oh yes, I asked them. So I go in and I ask the question, you follow a low sodium diet? And they say yes. And I said, and then I go through my list. Do you eat salami, bologna, sausage, hot dogs, lox, bacon, corned beef pastrami, capers, pickles, olives? And they look at me and said, that's all the good stuff. You want me to stop? So they think not using the salt shaker is a low sodium diet. So be very specific and ask. Cognitive stimulation during the day for people with dementia can help them sleep better at night. Music therapy can be very helpful. Number of years ago, we did a study at Beth Israel of using non-drug alternatives to decrease prescribing of zolpidem on a unit. And music therapy was one of the things we did. And we did have melatonin as an alternative, and we actually markedly decreased the use of zolpidem. So, safe prescribing. Question 1, is it medically necessary? What's the diagnosis? I actually heard a talk last week where somebody was suggesting that when you prescribe a new medication, indicate prescribing for, because that will allow somebody else in the future to potentially deprescribe it if that condition is no longer necessary. Use non-pharmacologic approaches. Look at what your choices are in terms of efficacy and drug interactions, as well as the patient's lifestyle. Okay, I can't take a medication twice a day. It's pushing it for me to take it twice a day. So when I saw a patient prescribed hydralazine Q6 for their hypertension, I said, is that really realistic? Are they going to be able to take it? So what's their lifestyle like? What's their ability to adhere to it? What are their comorbidities? Like, do they have incontinence? And the diuretic is not the first choice for my hypertensive patient with incontinence. Is the drug going to affect their cognition? And should I think about it? Or their ability to take their drug? So I have patients who have cognitive impairment who can have a home attendant during the day and are reminded to take their medication once a day, but are not going to take the second dose. So how can I move those medications to a time when someone is going to be there? Belief system. We had a patient, one of our fellows is Japanese, and he has a number of Japanese patients. And they won't take, this one patient would not take a medication unless it's also available in Japan. That was his belief system. What's their quality of life? Is this medication going to improve their quality of life or their life expectancy? So for example, treating osteoporosis, it's somebody, if they have at least 1 year of life expectancy, then it's worth treating their osteoporosis with a bisphosphonate. Cost, can they afford the drug? Brand versus generic. I've had patients many times call me and say, I have to have brand named Synthroid. I won't take levothyroxine. And there was a time when they were felt not to be bioequivalent. That actually is not true anymore. And sometimes you have to, if you can't convince them, you have to give them the brand name. What's the safety for that particular patient? Okay, is it going to increase their risk of falls? You know, the patient I saw yesterday who has a history of falls, but has tremendous anxiety and has been taking Xanax every night and weighing her anxiety and alternative with her falls. Deprescribing. So as I said, this is one of my favorite things to do. If I can get a drug off somebody's medication list safely, I get very excited. So what are the considerations? The time. You're seeing this patient for multiple medical problems, and now you're going to sit there and try to sort and deprescribe. Don't try to do it all at once. One at a time. Maybe have them come back for a separate medication review visit. Okay, look at the priorities. Which drug is really a priority with side effects for me? What's the pill burden for the patient? You know, maybe a medication that they're not really taking. So we saw a diabetic who was given Ozempic by his endocrinologist, but he wasn't taking it. But the endocrinologist wanted him to. And we said, he's not taking it. He's not buying it. It's costly. He's not interested. Take it off the list. Patients can be reluctant, like the patient I mentioned before who said, I've been taking digoxin for 25 years. Doesn't have AFib, was put on it for congestive heart failure 25 years ago. There are better drugs with less toxicity and not such narrow therapeutic windows. Communicate what you're doing. To the subspecialist, to the neurologist, we told that we were stopping the galantamine. Ask the patient what matters most to them, okay? They may say, I don't care about the side effects because my anxiety matters more to me. I can't function. So what matters the most to them? There is a great website called deprescribing.org that can help you deprescribe. And this is just one of the algorithms for deprescribing benzodiazepines. So you can look at this if you have time or you're interested. So my rule 1, don't prescribe a medication without conducting a medication review. Rule 2, start at the lowest dose and go slowly. Saw a patient yesterday who clearly had some depression for a long time and had a life event, a sick relative, and was more depressed. And family wanted us to consider antidepressants, and son is very educated. And I said, we're starting at the lowest dose of sertraline. And he said, why? You need to put him on the dose that's going to be effective first. And I had to explain why you have to start low to monitor for side effects, and because an older adult may respond to a lower dose. I may not need 100 milligrams of sertraline. He may respond to 25. Rule 3, new symptom. Take away a drug before you add one to treat the symptom. So I'm going to quickly just go through 2 cases, more to show you the drug interaction that you can do on Lexicomp if you're not familiar with it. And to highlight some of the interactions. These were both real patients of mine. 91-year-old was admitted with limb ischemia, hypertension, hyperthyroidism. She has a history of GERD, a stroke in the past, AFib, had a pacemaker, a bioprosthetic valve, significant peripheral arterial disease, lives with her daughter, uses a wheelchair, has no home care service, but the daughter, when she goes to work, has cameras in the home to watch her mother. Hospital notes indicate she is alert and oriented ×2. There is no other mention of her cognition, of her sleep pattern, or of her mood. These were her admission medications. They took her meds that she was taking as an outpatient, or that the daughter brought in, whether she was taking them or not, and just prescribe them all, rather than looking at, does she need this now? And if you run all these medications in the drug interaction program in Lexicon, it does let you know that there are, some high-level drug interactions, which you would think about, like zolpidem and Percocet. But it reminds you, you might not think about warfarin and propylthiouracil. So this is, an easy way to load them in and say, this one is therapeutically important to me, this one is not. Mr. S was a 71-year-old man who presented as a new patient to evaluate dizziness and short-term memory to the clinic. He had a history of hypertension, hyperlipidemia, depression, a lung nodule, ETOH excess, depression, and dizziness, was complaining of constant dizziness. He had no hearing loss. He did some vestibular rehab. He had an unsteady gait. He used a cane. He had a few falls. He was seen at another institution and had a full cardiac workup, brain imaging, seen by ENT, seen by neurology, and was following with an outside psychiatrist who didn't use the same medical records of either of the other institutions following him. He did have short-term memory impairment. He was a retired teacher. Couldn't tell us whether he had cognitive testing done. And this was the medications he came in with. And it was pretty impressive because they all were prescribed by different prescribers. So he was seeing both neurology and psychiatry who were giving him different meds. He had multiple psychoactive drugs. He was getting naltrexone and antabuse for alcohol abuse or alcohol use disorder, which shouldn't be taken together. But not everybody knew what the other person was prescribing. And again, if you ran a program, he definitely shouldn't be taking sertraline with disulfiram with antabuse. And we were able to actually pull away many of his medications. His cognition got better, his dizziness got better, his ataxia didn't, but a lot of the other problems did. So medication can be friend or foe. Be careful as you prescribe. And I talked a lot, so we have 5 minutes or so. I'm going to stop and answer any questions that anybody may have, or let you share your own stories.
Thank you so much, Dr. Fogel. Would anybody want to share any anecdotes or any instance where they de-prescribed in your clinic at the Ryan Center or even in the hospital? Or ask any questions you may have right now.
So I guess my advice is always reconcile your meds. Don't assume that because the list came from another subspecialty clinic that it's correct. So reconcile it yourself. Sometimes busy practitioners check off meds reconciled and aren't necessarily doing it every visit. So please reconcile all the meds and ask your patients about anything they may be taking that's over the counter, herbals, prescribed from other places, other countries. I've had that experience as well. And look for the drug side effects and interactions. And don't be afraid to carefully de-prescribe medications which may no longer be benefiting a patient. So thanks for giving me this opportunity to share this with you. And I hope that you at least take away some tips that you'll use in your clinical practice.
Thank you so much. We definitely will.